The North Carolina AIDS Training and Education Center at UNC Chapel Hill is presenting not just on PrEP today, but a PrEP network webinar. This webinar has two primary objectives. We want to train everyone on this call about PrEP, and we want to grow the statewide PrEP network of providers. We want to have every practice in the state that provides PrEP to be trained, supported, and listed on our map of PrEP providers. And we'll talk more about that towards the end of the day. Also, after your registration is confirmed, we'll be sending each of you a certificate of completion for this training and be in touch about other PrEP network information and activities. And in fact, if you're hearing the sound of my voice and you've not established your contact with us in terms of who might already be providing and treating at your site, please get in touch with us because we want to have all of your contact information. This webinar is going to be led by Christopher Hurt, MD, Clinical Assistant Professor at the UNC Chapel Hill School of Medicine. His research interests include PrEP, hepatitis C co-infection, substance use in HIV-positive patients, and HIV home testing. And in fact, if you want a really great presentation on home testing, go to the video section of our website and check out Dr. Hurt's presentation titled, Do Try This at Home. In addition to being a terrific clinician and researcher and a great friend to the training program, Dr. Hurt enjoys woodworking and recently built his own dining room table. We are not going to go any further. We're going to get started. Dr. Hurt, take it away.
Thank you very much, and thanks for the shout out for my carpentry skills.
Sure.
As Michelle said, I really appreciate everybody coming to the webinar and participating. This is really clinically focused, and so the goal here is to give you a sense of what a clinical encounter might be like where you weren't originally thinking that you'd be getting into PrEP or going down that rabbit hole. And I've had a couple of these so far where it just became obvious during the course of the interaction that this person could really benefit from PrEP and needs to know more about it. So that's the kind of basis for this presentation today. And we'll go ahead and get started. I have no conflicts of interest, so I have no stock in anybody, although I kind of wish that I did. My funding comes from the National Institute of Mental Health for a grant that's related to HIV home testing, as Michelle mentioned a minute ago. All right, so you're going to be meeting Demetrius in your clinic. Demetrius is 24 and African American. And he's coming in because he's got a discharge coming from his penis, and he's alarmed about this because he's never had anything like this before. He describes some dysuria that preceded the discharge by about a half a day or a day. But overall, he's kind of noticed the onset of symptoms for about 36 hours. So, and this is clearly new. He knew this is not normal for him, and so he's a little freaked out, and he's coming in for evaluation. He has no constitutional symptoms, no other things going on. It's just the discharge, and he's very nervous because again, this is the first time that he's dealt with something like this. I wanted to take a brief moment and just talk a little bit about sexual history taking because it's important in the context of visits that are related to PrEP, not only for people that are going to be on maintenance with PrEP, but also at that initial visit to assess the overall risk profile of that patient before you start PrEP. So some general tips that I talk to people about with respect to sexual history taking. The first thing I would suggest or really encourage people to do is to avoid preface statements. Things like, now I have to talk to you about some sensitive issues, or I don't want you to be offended by what I'm going to ask you. Because it sets the tone where everybody kind of gets a little bit freaked out that, uh-oh, I know this question is coming. So I think that in my practice, and I encourage the trainees here at UNC, to incorporate it as just kind of a boring overall part of your social history, where, in the same kind of sentence as you're asking about smoking, then you ask about sexual activity. And if you make it routine and as kind of boring as possible, it kind of puts people a little bit more at ease. You're not quite as worried about getting people offended or sensitivities raised. think the other thing that's really important is to make sure that your definition of sexually active matches their definition of sexually active. There are a lot of people who don't view oral sex as sex, for example. So only penetrative vaginal or anal sex is viewed as being sexually active. And there are some cultural connotations as well. So among Latinos and Hispanics, some people view only the receptive partner for anal sex as being that person as being passive, where and so if they're the bottom for anal sex, they may not recognize the term sexually active because they view their role as being passive. So just to be aware of some of those subtleties when you're taking your sexual history is important. I think it's also really important to emphasize that it's okay to use colloquial terms. So the minute that you whip out medical jargon, you lose some people. So whatever the patient would ordinarily answer to their friends, using that language is okay. So you're not going to lose your job. The patient's not going to sue you. And they're probably going to understand better about what you're actually saying if you say, for example, come instead of ejaculate. It actually drives me kind of bonkers when I see people take sexual histories like this, and the patient is clearly not going to understand, but the provider has flipped into medical jargon. So avoid it whenever you can. So my standard brief history for basically everybody that I see in my clinic, which is mostly people living with HIV, my standard brief history goes like this. Do you have sex with men, women, or both? I used to flip it around so that for men, I would ask, do you have sex with women, men, or both? And then I said, forget it. It's too much trouble. So I just do the standard men, women, or both for everybody. Again, I make it boring and kind of, I don't really give it any thought anymore. For men who have sex with men, I ask them, do they top, bottom, or both? So a top is the insertive partner for anal sex. The bottom is the receptive partner. And then people that are both insertive and receptive typically refer to themselves as being versatile. So if you use these terms, people will understand what you're talking about. So when you say things like, are you the insertive partner or the receptive partner, not everybody understands the kind of tab A and slot B terminology there. So it's important, I think, to get at the terms where people are actually going to understand. And then I ask, are you in a relationship with anybody? I think it's important for risk assessment in general and to kind of get at condom utilization. If they're not in a relationship, I ask them, are you having sex with anyone? And if they are in a relationship, I ask them, are you having sex with anyone else? And also, do they think that their partner, or do they know if their partner is having sex with anyone else? So understanding where contracted relationships may have contracted non-monogamy, where it's an open partnership or an open relationship, where there may be other people and other sex partners, where other STDs may be kind of creeping in. So understanding that is really important in context. And then finally, I ask people, how often do you use condoms for whatever it is that they've described that they do sexually in the rest of the history? And I switched this. I used to say, do you use condoms? And I heard somebody once talk about taking a smoking history. And instead of saying, do you smoke, saying, how often do you smoke cigarettes? Because when you say, do you, there's an implicit yes, no. And the patient knows that you want them to say that they don't smoke. So if you ask somebody, do you use condoms, the patient knows that you really want them to say, yes, I am. And so they're going to answer you, yes, that they are. But if you say how often, then you're really asking them to quantify it, and they can't kind of fall into a bucket of yes or no. So I think that, and I've had good success with rephrasing that question in that way to get a little bit clearer understanding of how frequently condoms are a part of the equation overall. So getting back to Demetrius, he has sex with men. After you've asked your sexual history questions, he discloses that he has sex with men, which is important. So it's important that he felt comfortable enough with you to disclose this fact because it's important for the overall risk assessment. He's not currently in a relationship, which is also important to kind of keep in mind. He meets partners at clubs and online and is using apps as part of that as well. He says he uses condoms most of the time. It's not perfect, but he does use them most of the time. And interestingly, he tells you in the context of the history that he just finished a PrEP regimen about 2 months ago after a partner that he was having sex with, the condom broke, and afterwards disclosed to Demetrius that he was HIV positive. So Demetrius went to an emergency department and got on PrEP. So let's talk about condoms and about PrEP. So condoms are not perfect. And I think it's important to kind of address this sacred cow within public health. We view condoms as being perfect, and we've leaned on them for a really long time, appropriately so. They're highly effective when they're used correctly. However, it's not 100%. So there were 2 studies that were done looking at the literature to assess how good is good. And these 2 studies were specifically done to look at HIV prevention. So consistent use of condoms reduces the risk of HIV transmission. Again, this is not considering other STIs, just HIV transmission. It's 70% among men who have sex with men and 80% among heterosexuals. And when I saw these 2 numbers, I did a double take and I felt a little upset because I thought this number was closer to 90 to 100%. These take into account failure rates. They take into account non-use. It takes into account things like the partner thinking that their partner is wearing a condom but actually isn't. So overall, they're not perfect. So it's just important to keep that in mind. That for a long time we've leaned on them, but it's an imperfect tool. Furthermore, recent studies have shown that about 90% of heterosexuals had at least some condomless sex in the prior year. So this is not just a men who have sex with men issue. This is an issue among heterosexuals as well. And then with respect to anal sex, the study by Rosenberger and others that was published in 2012 was a large internet-based survey. And it showed that over half, just over half, 55% of men who have sex with men, at the last time that they had anal sex, they didn't use a condom. And that's a large number for those of us in public health and who deal with HIV, and an alarming number, I think. But I think we also don't appreciate the fact that heterosexuals have anal sex also for a variety of reasons. And 30% of them didn't use a condom with the most recent episode of anal sex. So we know that anal sex is the most efficient, next to injection drug use, anal sex is the most efficient vector for transmission of HIV. And so the anal sex issues are very important. And condom non-use, condomless anal sex, is important to kind of quantify and get a hold of when you're taking a sexual history or assessing a patient. So I just wanted to touch very briefly on PrEP also, because PrEP, there's a lot of excitement about PrEP, and I have a lot of people that ask me, well, whatever happened to PrEP? I think there's a lot of people that also kind of forgot that it existed. It's been around since the mid-1990s for occupational exposures, and then it was extended into non-occupational exposures, so sexual assault victims, condom failures, etc. The key points here are a few things. The first is that the earlier the better. So PrEP has been studied in animal models and in cohort studies looking at people that have had exposures, either occupational or non-occupational. And it's clear that the earlier you start medications, the better. Ideally within minutes, not hours, and ideally within the first 24 to 48 hours, not the first 72. 72 hours is the threshold, however, so that's the point beyond which PrEP is probably non-effective for prevention purposes. So again, the earlier the better. Historically, the recommendation had been Combivir, so the very first 2 HIV medications that we had available combined as a single tablet. That's AZT and lamivudine, or 3TC. Combivir plus Kaletra, a protease inhibitor, and that was for 28 days. The problem was that Kaletra gives people rip-roaring nausea a lot of the time. And especially if you're not used to taking medications, which a lot of people that are on PrEP regimens are young and otherwise healthy and aren't taking a whole lot of medications to start off with. So study after study showed that the completion rates for this particular regimen were really, really crappy. And so there was a push to look at alternative regimens that might be more effective because they were better tolerated. So in 2013, there was a paper published in a journal called Infection Control and Hospital Epidemiology that was an update of the guidelines for non-occupational exposures. And in that guideline, they suggested and they recommend that the PEP regimen ought to be, instead of Combivir and Kaletra, Truvada and Icentrus. So Truvada is the same agent as PrEP, which we'll talk about here in just a second. And then Icentrus, which is an integrase inhibitor, the first one in its class, is extremely well tolerated by most people. Already in studies of this particular regimen, the completion rates are miles and miles better than the traditional Combivir and Kaletra regimen had been. There is an update of the non-occupational guidelines that's coming, but it has not been set out yet. And I should just also add that the updated occupational guidelines, that is CDC and U.S. Public Health Service sanctioned. So it's not just expert opinion, it's the expert opinion of the CDC and the U.S. Public Health Service. Okay, so Demetrius is honest with you, and he says that he's tried to use condoms consistently. He just doesn't enjoy sex as much with them. And this is a comment that I know a lot of you have gotten from patients or clients over the years. He also says that he doesn't always have one handy. So if he's out at a bar or a club and he meets somebody, if they go to hook up, then he may not have a condom on hand, and neither may his partner. And basically, he just says, they just get in the way. And again, this is, I think, a frequent comment that a lot of you have encountered. So if you're like me, the condom thing, this was a very difficult, I'll go ahead and use the pun, a very difficult pill to swallow. Because I was born in 1977. I was in high school in the mid-90s, and I remember very vividly having a panel during my senior year of people living with HIV that came in to talk to us about the importance of safer sex and using a condom every time, because they were dying of HIV at that time. There was no effective combination treatment at the time that they talked with us. And so this was a message that really was pounded into my brain. And I think a lot of other people in my generation and the generation that lived through the worst of the epidemic. So condoms are a normative thing for a lot of people. And especially in public health, we really focus on condoms as being the end-all be-all. And they really are the most important kind of first line, because it's preventing not just HIV, but also other STIs. So when PrEP became a thing, I'll be very honest and tell you that I did not initially embrace PrEP. I was very skeptical. And I underwent a change of heart. And that change of heart was because I started to view PrEP as a harm reduction tool, more as a harm reduction tool than as a pure HIV prevention tool. And that reframing it, whereas thinking of, I'm trying to help people do whatever it is that they're doing already to do it more safely. And to try to meet them where they are, rather than forcing them to come to my side, which is the condom side. So that change of mindset made a big difference for me, and then it made me more open-minded and more willing to look at the literature and look at the evidence more objectively. So I would encourage those of you who are thinking about PrEP, but if you're in your heart you say, I don't believe this, then weigh the evidence that I'll show you here in a few minutes and think about your own kind of feelings and motivations with respect to PrEP. But change is going to be difficult, because moving from a message where if you don't use a condom you're going to die, is a very difficult thing. It's going to be a very difficult thing for a lot of us to do. So what is PrEP? So PrEP is pre-exposure prophylaxis. And the idea is old, actually. So the idea is rooted, the oldest version is basically malaria. So we know that if you're traveling to a part of the world where there's malaria, if you take anti-malarial medications before you get to that part of the world, and while you're there, if you get bitten by a mosquito, the drug is already there to kill the malaria. And so you won't get malaria. So the same idea has been brought forward and tested and now proven for HIV, that if you take anti-HIV medications before an exposure, the risk of getting HIV infected is dramatically reduced. So that's the core message. And there's a variety of other lines of evidence that support PrEP and supported the initial research and development behind it. Of all of the different HIV medications that we have, there's one drug that was really kind of got out front as the agent for PrEP, and that's tenofovir. So tenofovir is by itself, Viriad is the trade name, or Viread, some people say Viread, and then it's half of Truvada. So tenofovir became the most studied agent for PrEP for a few reasons, a few specific characteristics of that drug. The first is that the pharmacokinetics of the drug allow for infrequent dosing. So for any of you who yourselves take medication or have patients or clients where you're dealing with a choice between a once daily and a twice daily medication, you're going to want to take once daily. People forget the second dose. People have other things that they do. And so taking the second dose of medications is difficult. So that was a very early parameter here for PrEP, was that we wanted this to be a single pill regimen, a one-time-a-day regimen. Tenofovir also has very few drug-drug interactions. So there was a recognition that the people that were going to be using PrEP were pretty healthy, but they may have issues like blood pressure or diabetes or asthma, or other things that you don't want your medication, a preventive medication, to get in the way of treating the other stuff. So having few drug-drug interactions was also really important in the selection and development process. We have a long track record with this medication in people living with HIV, and we know it. We know the pluses and the minuses, and so the safety profile is very well characterized and very well tolerated. So we knew that. That was also important. And then finally, resistance to this medication is a little bit less likely compared with some of the other HIV medications that we use. And that's also important, although in the grand scheme of things, the data suggests that this is maybe a little bit more theoretical than actual. So resistance has been uncommon in PrEP studies thus far. And that's an important point. So the PrEP, the resistance part, it's less likely to develop with tenofovir. All right. So let's talk about the clinical trials very briefly that were leading to the approval of PrEP. So this slide summarizes the main studies of oral PrEP. And I just point out a couple of things. The first thing is that you see a negative numbers and you see positive numbers on the effectiveness down at the bottom. 0, the midpoint, really means that it does nothing. So you don't want any of the bars to touch that midpoint, because that means you have no effect. So you want it to be clearly on one side or the other and not kind of flirting with the midpoint. So there were 5 studies that showed a protective benefit of taking daily PrEP, either with tenofovir by itself or with combination emtricitabine and tenofovir, which is also called Truvada, the brand name. So 5 studies showed that this works, that it had a protective benefit, and 3 studies showed no benefit at all. And this was perplexing to a lot of people. And when I saw these original data, This is what made me say, oh, this is probably not ready for prime time. And then I kind of looked some more at this, and the key here is the adherence part. So the adherence to the medication is everything. Just like people living with HIV, and just like people dealing with any kind of chronic medical condition or for preventive purposes, it doesn't do any good if it stays in the bottle. So it's not rocket science that the more compliant or adherent that you are with the program, the better the effect is going to be. And that's clearly what was shown in these studies. So the studies that didn't show an effect, the people overwhelmingly did not take the intervention. They did not take the medication as directed. So if we pull out two specific studies just to use as an example, so PrEP, which was the first and to date biggest study in gay and bisexual men, so men who have sex with men, as well as transgender women. And then the Partners PrEP study, which was done in heterosexual, established heterosexual couples in Eastern Africa. So if you take all the participants, the people who took the medications, the people who didn't, and everybody in between, the overall protective efficacy for PrEP was only 44%. So not very spectacular. Partners PrEP was substantially better, so better than 50-50, so in the 62 to 73% range. However, if you consider just the people who really took the medication, and that was judged by doing blood level measurements of the drugs, the high adherers, the protective efficacy was incredibly better, so in the range of 90 to 100%. So this is just important, and this is a important theme here for PrEP, is that the adherence part is critical. You have to take it for it to have protective benefit. So PrEP did another thing that was important in the overall grand scheme of things, which was after the main study was done, the randomized controlled trial part, that was placebo-controlled also. They did an open label extension, so PrEP Olay. And the open label extension looked at drug levels in patients and the incidence of new infections over time. And they showed that if you took 2 to 3 tablets per week, so not very good adherence, 2 to 3 tablets per week, that equated to about 90% protective benefit. However, if you increase that by just one, and so effectively more than half the days of the week to all of the days in the week, you have 100% protection. So the point here is that there's some forgiveness, that adherence is important, but it doesn't have to be perfect, although we should strive for that with all of our patients. But if you forget a dose, it's not the end of the world, and it doesn't leave people in the lurch. So 4 to 6 tablets per week, 4 or more tablets per week, has 100% protective efficacy. So the key points here to summarize: daily dosing gives you the best protection, which makes sense. If you're using this as a shield, as a pharmacological shield against getting infected, if you give any chink in the armor, then it's going to give HIV a way to get in. And so you want the armor to be the strongest and most complete that you can make it, and daily dosing gives you that. However, if you go out and you didn't take your Truvada that night, it's not the end of the world. So the medication gets in the system, it stays in the system, and so there's some forgiveness involved. So an occasional misdose doesn't put people at a significant risk. There's still some inertia, basically, with previous doses taken. But again, everybody should be striving for adherence, for perfect adherence. And then if you don't take it, it gives opportunities for the virus to enter and for you to become infected. So the daily adherence part is everything. And that's a critical component of the counseling part for patients that are going to be initiating PrEP. So based on the clinical trials evidence and the subsequent studies that looked at pharmacological data and adherence, a whole bunch of things, the FDA looked at all of that and said, yes, this is for real, and this is ready for dissemination. So that was in July of 2012. And this was a big deal. So this is the first time that any antiretroviral has been approved for HIV prevention purposes. And so this is an important milestone in HIV history, basically. It took another 2 years for the CDC and the U.S. Public Health Service to issue formal guidance about how to do PrEP. And they issued a two-part books, basically. One is 60 pages and the other's 40, that describe to clinicians how do you administer PrEP in clinic. And they go in great detail about the clinical trials evidence behind it, and also provide some guidance for how do you do billing and coding related to it. So the intention was to be a one-stop shop for people doing PrEP prescribing in practice. Unfortunately, these guidelines did not give any guidance about how to get PrEP into the hands of people who need it, or how to create systems in order to deliver PrEP. It was just focused on, at the point of care, what do you need to do this safely, and how do you monitor it? So Demetrius has heard of PrEP. He's heard the term, but he doesn't know that much about it, he tells you. He says he read something not terribly long ago that he thinks about some study in San Francisco that sounded like it was pretty good. But he seems skeptical. He's clearly not on the bandwagon yet, and appropriately, he hasn't heard that much about it. And then he brings out one of the things that gets trotted out a lot, which is, I've heard these medications are toxic. And I'm sure that you've had patients or clients with HIV that have some reluctance about starting medications that say, you know, I had an uncle who died after they started AZT, or, you know, I've heard online, or I've talked to people who say these medications are highly toxic. So, and people have gotten this in their heads a little bit about PrEP as well, through the grapevine, online, and through word of mouth. It's unfounded, and we'll talk about that in a second. So that San Francisco study that Demetrius heard about was done at Kaiser Permanente, and so Kaiser is the largest integrated health system in California, and this was a 3-year study, or 2.5 years, from July of 2012 through February of this year, done only in clinics within the Greater Bay Area. So they took, and this was really focused on clinical care, so implementing PrEP just how you would do it in your own clinics, writing prescriptions, having people come in for follow-ups, not having study coordinators track them down or anything like that. This was pure clinical care. So in this study, they looked at just over 1,000 people who were referred for PrEP by a provider within the Kaiser system, or to a provider within the Kaiser system. 80% of those people referred for PrEP were evaluated in person, so were linked to care, to PrEP care, and 82% of those linked initiated PrEP. Over the course of 388 person years of follow-up, so a fairly significant follow-up period in aggregate, they saw 187 new STIs among PrEP users and 0 new HIV infections. And this was a big deal, and I think this is a big deal, because this is the first study in the US that's shown clinical care of PrEP can effectively halt new transmissions in people that are clearly at increased risk. So had this study shown there were like 15 STIs and no new HIV infections, nobody would have taken as much notice as this study showing almost 200 new STIs with no new infections. So clearly this was either a self-selected population or an already at high risk population that is the target. It's the group that could benefit the most from PrEP. The other thing I would point out to you about these data is that there seems to be a PrEP cascade, similar to what we're experiencing in people living with HIV, where every step along the way we experience a drop-off from people getting diagnosed, to entering care, to getting on ARVs, to getting suppressed. There are also step-offs in the PrEP cascade. So there are people that are being referred for care that never show up to the visit. There are people who make it to that visit but never start PrEP. So with every handoff come issues. And so minimizing the number of handoffs is one of the goals of PrEP implementation. But any of you who work in clinics or public health systems know that is much, much easier said than done. The other study that I think is important to talk about is PROUD. And PROUD predated, the results of PROUD predated the Kaiser Permanente study by several months. This was a study that was done in London in sexual health clinics, in 13 sexual health clinics within basically the gay ghetto area of London. And it was over a 2-year period from 2012 to 2014. And this study was, at the time, and still actually currently, in the national health system in England and the UK, there is no access to PrEP. So this was the only way for people to get PrEP if they wanted it. And so they launched this study with an eye towards mimicking clinical encounters, similar to what the Kaiser study looked at. So again, in the PROUD study, there was no study coordinator reminding people to come in. There was no text messaging for follow-up reminders and so forth. This was just writing a prescription, seeing if people come back, seeing if people pick up the prescriptions, and so forth. So they randomized 544 men and transgender women in PROUD. And they already knew by the time, so the start of PROUD was after FDA approval of PrEP. And FDA does not apply in the UK. And so they recognized that this is a real tool and it would be unethical of us to do placebo controlled. So they said, instead, let's have half the group start now and half the group wait. And the group that waits will serve as the control. So half started immediately and half delayed initiation. And at a regularly scheduled Data Safety and Monitoring Board meeting, partway through PROUD, the DSMB said, stop the study. And usually in clinical trials, that gives us palpitations because it means, oh, crap, there's either somebody's died or somebody's liver disappeared or something like that. This was not the case. DSMB said stop because this was 86% protective, which was a huge number for clinical care. So this was not a highly random, this is not a highly structured intervention. This was clinical care, and this was a big number. So 86% protective efficacy is a big number in public health. If you reframe that number in another way that internists and physicians, and I think other people in epidemiology and public health recognize as the number needed to treat. So the protective efficacy number can be retooled into the number needed to treat. And the number needed to treat, or the NNT, is a figure that is becoming more popular because it allows us to gauge how effective is something. How many people do I need to intervene with in order to prevent one bad outcome? And so you want the number to be low. Ideally, every person you intervene with, you prevent an outcome in that person. So a perfect number needed to treat would be 1. The 86% translates to 13. So for what that means is that you have to take 13 men who have sex with men and transgender women that are at risk for HIV infection and treat them for 1 year to prevent 1 HIV infection. That's a pretty darn low number needed to treat. To put that in context, for primary cardiovascular prevention with aspirin, which everybody in the world would accept is a reasonable intervention for somebody at increased risk of a primary coronary event, it's 1,667 people that you have to treat for 1 year to prevent 1 stroke or heart attack. That's a big number needed to treat. For statins, like atorvastatin, for example, you have to treat 104 people for 5 years to prevent 1 primary event. So a substantially larger number. So for people that are data and numbers nerds, this should make you excited. This is a big number. So a small number needed to treat and a remarkably small number needed to treat, and one that is substantially smaller than things that are widely accepted in medicine already. So statins and aspirin, nobody would put up a fuss with. and yet PrEP has been slow on the uptake. So what are the side effects? The first thing to note is the startup syndrome. So there's a substantial number of people that get flatulence, nausea, and a mild headache within the first couple of weeks of starting PrEP. And for most people, that resolves within the first month. It's not everybody, and for some people, they do have to discontinue, but it's a very small number of people. So overwhelmingly, within the first month, these symptoms go away. There are two main things that we worry about with tenofovir. One is kidney function, and so tenofovir is the main kind of culprit behind the side effects. Emtricitabine, the other half of Truvada, is pretty inert. It doesn't do much, but tenofovir does have some effects. So there was a study that was done before tenofovir became FDA approved, where it was available for compassionate use in people living with HIV. And so they looked at 10,000 people, over 10,000 people who got tenofovir as part of that compassionate use program, and only 2% of them had any kidney problem. And that's a very small number overall. And that any is really any. So if there's any weirdness in the creatinine, it got counted. So the number of people who actually had significant kidney stuff is smaller than that 2%. But it's 2% had any renal abnormality at all. In another study that looked at people that started with baseline normal creatinine and that had some abnormality progress while on tenofovir therapy, they looked at what happened to those people when they stopped treatment. So 60% of those people normalized their creatinine within a median of 17 months. 10% improved somewhat but didn't get back to baseline. And about a third had no change at all. So it appeared that whatever damage had been done was done. However, those percentages are deceivingly large. So just keep in mind that's 2% of everybody, well, less than 2% of everybody. And then the majority of that less than 2%, they get back to normal. So if they do run into any trouble with the kidneys, it's reversible. It's not like these people are going to wind up on dialysis. So it's an increase in the creatinine or a decrease in creatinine clearance, but it is reversible for most people.
Dr. Hurt, may I interrupt you
Sure.
for a very quick point? Do you personally think, or have you seen evidence that this particular issue, the issue around the kidneys, is one that is making people think that the PrEP may be toxic? Or do you think toxicity about HIV meds has sort of passed over onto PrEP and people aren't really even aware enough to think that it's some side effect related to kidneys?
Yeah, it's a really good question. The answer is yes to both of those. I love answering yes to two questions at once. The first part, the carryover, well, I guess that's the second part. The carryover is definitely there. There are a lot of people who they think HIV medications and they have a picture in their brain of somebody with lipodystrophy. And they believe that whatever HIV medication you're going to start, you're going to wind up looking like that. You're going to look like you have AIDS, right? So we hear that a lot. The thing that I hear more than kidney is liver. So people believe that if they start PrEP, they're going to have liver problems, which tenofovir does not cause liver issues. Basically, period. It doesn't cause liver issues for people. And so monitoring liver function is not even part of the recommended monitoring for PrEP. So I hear liver more than I hear kidney. But there are people that have heard about this at some point or know somebody who is on Truvada and had their doctor tell them about kidney stuff before. So there is some awareness, but it's more liver than anything, which it seems interesting to me that the urban legend that's out there is liver related and not kidney related.
Thank you.
The other main side effect with tenofovir is bone mineral density. So and this was of concern for a lot of people and was studied extensively in the PrEP studies as well. Not just in people living with HIV. So this graph actually is taken from a large study of people living with HIV, however. So what it shows is that there's an initial decline in bone mineral density of about 2 to 4% within the first year. It's pretty rapid, and then it stabilizes over time. And it's actually reversible as well. So there's this overall decline and then stability after that. So it's not like people are going to progress into osteopenia or osteoporosis the longer that they stay on tenofovir. And then it does improve after stopping. So if in switch studies and other studies where tenofovir has been discontinued or switched for an alternative agent, bone mineral density does return towards baseline. So getting back to Demetrius, he says, that doesn't sound all that bad. Those things sound like things that aren't really a concern for me. So overall, he's kind of receptive to the idea. Then he brings out the next whammy, which is PrEP is for sluts. So I've heard this from people. It's all over the internet, and there's an understanding among people that there's just it's only for people that are promiscuous, and that there's this morality associated with PrEP that is a deterrent for a lot of people. So I think it's worth noting that this is out there. There is PrEP stigma that is absolutely real, and it's one of the things that you may have to disarm patients about when you're counseling them or talking to them about PrEP. So you should get at whether or not they view that PrEP is a mark of some kind on them. So so Demetrius says, people say PrEP's for sluts, but I don't hook up that much. I don't think that I hook up that much. But is this still something that you would recommend for me, even though I don't hook up that much? And also, by the way, isn't this going to be like $1 gajillion? So who should get PrEP? So in those guidelines, the U.S. Public Health Service guidelines, there's a clear definition of who should be getting PrEP. The key thing, you have to be HIV uninfected. And it sort of makes sense, but you need 3 drugs to treat people with HIV, and Truvada is only 2. So it will not do the job. So you have to be HIV uninfected before you start, or else you will wind up with resistance issues. In addition to that, you have to have any HIV positive partner. And interestingly, they don't make a distinction about the viral suppression status of that partner. So that your partner could be undetectable and stably undetectable for years, and that does not discount you or disenfranchise you for being a candidate for PrEP. So that's important to note. So having any HIV positive partner, condomless sex, any STIs in the past 6 months, a high number of sex partners, which is not defined by the CDC and U.S. Public Health Service. If you're in a high prevalence area or sexual network, if you're a commercial sex worker, or if you have experience with drug use. So if you have shared injection equipment, or if you just came out of rehab. So with the recognition that that period after you get out of inpatient rehabilitation for substance use is a high risk period for relapse. So that was clearly a risk group that they wanted to target. And there's data that show that PrEP works in injection drug users. So let me address very briefly the prevalence part, the high prevalence sexual network. We are a high prevalence area, period. So the Southeast, the whole Southeast is high prevalence. So these are data from AIDSview, which is a service of Emory University and the CDC that maps out prevalence data, the rates of people or the proportions of people living with HIV within specific jurisdictions all around the country. And so if we drill down, so you can see the deepest reds are, if I showed you the whole US map, you would see that the deepest reds are in the Southeast, with Southern Florida, South Carolina, and North Carolina very well represented in those deep reds. Within the state, the eastern part of the state has a higher HIV prevalence than the rest of the state and the Piedmont. So there's a belt through the coastal plain part of the state with high prevalence. And there are clear demarcations in prevalence based on race and ethnicity. So among Hispanics and Latinos, the prevalence is higher than in whites, and in blacks, it's substantially higher. So there are clear differences that are here as well in North Carolina. And the same is true all across the country, that differential between Latinos and whites and blacks and whites. And then I'll give a shameless plug for a study that we did with the state and This study looked at a sexual network, a very large sexual network that was principally of Black men who have sex with men. And what we showed in this network is that at least a third of people in the network were HIV positive. So that does not take into account how many were on medications or linked to care. And I should also say that there was a substantial number of people that we could not ascertain their status. So at least a third of people were positive. There may be substantially more people in sexual network that were positive. So the point is that this is clearly a high prevalence area and a high prevalence sexual network. So it's important to keep both of those factors in mind when you're counseling patients, that we are absolutely in a high prevalence area. Then the other question that comes up is about riskier sex, and this idea that that has been brought out with birth control in the 60s and 50s and the HPV vaccine, and now with PrEP, that if you start taking something and you think that you're going to be invincible, that you're going to be disinhibited and have more sex and put yourself at greater risk. So in the literature that's termed risk compensation. This has been studied in basically every major PrEP study to date, and looking at a variety of different indices. And depending on how you look at it, regardless of what measure you choose, the indices of risk are stable or reduced. I'll point out these data from Ipergay. That's a study that was done in France and in Quebec that looked at high-risk men who have sex with men, and looking at an intermittent PrEP regimen, which I won't get into, but the point here is the sexual risk data. So the mean numbers of sexual acts and the number of sexual partners over a 2-month and 4-week and 8-week period, respectively, at the left-hand side, fairly substantial, fairly sexually active group of people. And at the bottom right, 70% of them were having receptive anal sex without a condom. So this is a very high-risk group. This is exactly the group that would benefit the most from PrEP. So already there was a high-risk population. What I'll point out, though, is that these are statistically non-significantly different over time. So placebo compared to PrEP, and then over time there were no big differences. So it's not like people started on something and said, well, I'm having some gas, I must be on the actual drug. That means that I can be riskier in whatever I'm going to be doing. So there were no big differences. Whatever level of risk people were at baseline is where they wound up at the end. Anecdotally, I can tell you there are absolutely people that are increasing risk after starting PrEP. There are also a substantial number of people, and I have both groups represented in my clinic, that start PrEP and have less sex, in part because they're paying more attention to their own sexual health, and in part because of other things like having the riskiness or the danger part taken out of it, and people that have compulsion or risk-taking behaviors. So it can go both ways. On average, however, most people do not substantially change their risk behavior after starting on PrEP. The other question that we get is, how long is it before you're protected? So if you take the levels of the active drug in specific body tissue, so rectal tissue, blood, and cervicovaginal fluid, it takes about a week for rectal tissue to get essentially saturated with the medication, and it takes longer for blood and cervicovaginal tissues. So if you add another week on to both of these, it's important. So there's an additional time that before you're really fully protected. And then the washout period is the same as the wash-in period. So it takes about 7 days for the medication to completely disappear from rectal tissues and 20 plus days for cervicovaginal or blood.
So Dr. Hurt, you might have a slide that talks about this further, but it's a question that we got in a timely way. Is there a waiting period after beginning treatment before unprotected sex is less risky? And I'll even reworded it for myself. When you counsel people who have elected to go on to PrEP, what do you say to them about when they should feel that they are protected?
Yeah, it's a really good question. And for men who have sex with men, it's at least 2 weeks is what I tell people. And that's being really conservative based on these numbers. So if it takes a week for rectal tissue to get optimally protected, I add a week just to make sure that people are going to shave some time off no matter what. For women and injection drug users, it's longer, so it's a month. So that's what I would tell people, is that for heterosexual couples and for injection drug users, it's a month. For men who have sex with men, 2 weeks.
Thank you.
It's a very good question. Thank you for asking. And then Demetrius wants to know how much this is going to cost. So if you had to pay this out of pocket, it's between $1,300 to $1,600 per month. However, this is FDA approved for this indication. And if you code it correctly, you're not going to get into big issues with the insurance company. So insurance does cover this, and Medicaid does cover this. I thought that I was going to be in pre-auth hell for a while. Initially, I've yet to have a pre-auth that I had to complete for PrEP. So, and I'm sure some of you have run into it already, but there are not big blockades for this. There's some general hoops to jump through, but not huge blockades on the insurance side. There are also fairly generous access programs and co-payment assistance programs that are available for PrEP. And it's potentially free from the manufacturer if the client or patient has no source for insurance or prescription coverage, and if their income is less than 500% of federal poverty limit. So for a single person, that's about $58,000 per year. So I can tell you, I've yet to have anybody that had to pay for PrEP out of pocket. So I got them copay assistance with insurance, or we went through medication assistance programs. There are absolutely ways to get this done. And NCA Tech, we have on the For PrEP prescribers page, we have some resources for people that have questions or concerns about how to get this paid for. The manufacturer set up their own website for PrEP. So it's start.truvada.com. That's different than the website that's for people living with HIV. So just if you put in just Truvada, it may direct you to a different website, and the PrEP stuff is actually not on that website. So you have to direct to the correct one at start.truvada.com. So your eloquent description of all of the evidence has won Demetrius over. He thinks this is a pretty cool idea, and that he thinks that it could benefit him. He sees the value in it. And he wants to know, what do I have to do to get started? So we have lots of resources online, we put together resources that are directed at providers that are thinking about PrEP prescribing, providers that are already prescribing, and for consumers that are interested in where to get connected to PrEP care, or that may have questions themselves. So for PrEP prescribers, we have a step-by-step guideline that basically we took the U.S. Public Health Service guideline and distilled it to the what do you need to know right now parts, and put some general recommendations about best practices here at UNC in there as well. So that's available for people that are doing PrEP prescribing. For consumers, we have a map that if you're doing PrEP or about to do it and you're not on our map or haven't heard about it, we want to know who you are because we want to list you. We want consumers to be able to find you, and we want you to be able to help serve them. So the map is really important, and we've definitely have a lot of people that have gotten connected to providers by finding our map and getting connected that way. So the first step here in determining how to get started with Demetrius is to determine the clinical eligibility for PrEP. So that's in 3 different categories. Liver health is first. So the U.S. Public Health Service guidelines recommend doing viral hepatitis testing. The most important test of these is surface antigen, hepatitis B surface antigen testing. They recommend doing surface antibody and hepatitis C antibody as well. The Hep B surface antibody is so that if they're not immune and uninfected, that you can immunize them. The Hep C is because there's a recognition that hepatitis C can be sexually transmitted depending on rough sexual practices or sex practices that result in bleeding. So the only kind of critical test here is the Hep B surface antigen test. And you have to be aware that Truvada treats hepatitis B. And so there's at least a theoretical risk that people can flare if they start Truvada and they have Hep B and then they stop Truvada. This has been studied, and the flares are very, very uncommon. So it's just to be aware that there's caution here. It's not an absolute contraindication. Renal function is also important to assess because of that, the toxicity, potential toxicity of tenofovir. Creatinine clearance has to be over 60 in order to qualify for tenofovir. If it's less than that, you cannot do dose adjustment. There is no approved dose adjustment for tenofovir or for Truvada, like we do with some patients living with HIV that have renal disease. So you cannot do dose adjustments. Very, very important. There is no alternative if people have a creatinine clearance that's less than 60. And then assessment of HIV status is also very important, and I would argue the most critical aspect of this. So very briefly to review, you get RNA that peaks very early. You have P24 antigen that's made by the virus very early in infection. And then at the time that the antibody levels start to rise to detectable levels, that successfully clears antigen. So the antigen is a marker of early infection, but it disappears in most people that have chronic infection. So that's important to just keep in mind. The main recommendation is to do antigen-antibody combination testing, 4th-gen testing, which gives you diagnostic certainty within about 15 to 20 days after infection. That's pretty early, and that's overall pretty good. So antigen-antibody 4th-gen is what we strongly recommend that you use for testing purposes. That being said, you can use rapid testing in your clinic if it's by finger stick blood. You cannot use oral testing because it's not sensitive enough. So you have to use a finger stick blood as the specimen, or you can just send a blood sample for a traditional ELISA or EIA. This is the reason for that oral thing. The differential is that to reliably detect by oral fluid, it's at the 90-day mark after infection. So that's unacceptably late in the game here. So you need testing that can then diagnose things much earlier. And obviously you have to be HIV uninfected. Depending on the risk history for the patient, you could consider getting an RNA also. And that narrows your window. It makes it diagnosis possible closer to the time of infection than a 4th-gen combination antigen-antibody assay can give you. Viral hepatitis status and kidney function have to be determined within the month of starting PrEP, and HIV testing ideally should be within a week of starting PrEP. Sometimes that's not always feasible to do, but you should strive to make it happen if at all possible. Also, it's important to screen for symptoms of acute HIV, which are listed here. The patient has to be free of those within the month prior to the time that you're evaluating the patient for PrEP. Again, another level of security and safety here to make sure that the person does not have HIV that you're going to miss by whatever test you pick at the outset for initial screening. If you suspect acute HIV, the best thing to do is to send an HIV RNA, send a viral load. It gives you the earliest diagnosis possible, and it's more foolproof than antibody-based testing for this purpose for early diagnosis.
Dr. Hurt, this is the perfect time for me to get in a particular question that was asked. Actually, it was a comment, but I'll tee it up as a question. Basically, we're getting information that some folks out there using PrEP are thinking that it covers them for STDs as well. And the role of condoms, which you've definitely talked about, is key. So we had one person on the webinar with us to make sure to say that that message is one that should be going hand in hand with discussing PrEP. So let me just ask you, Demetrius came in to see you because he had an STD. So I'm sure you're going to talk about it here, but what are you going to say to him about STDs and PrEP?
Yeah, it's an important message, and I wholeheartedly agree, is that this only prevents HIV for sure. There's some evidence that it may prevent herpes infection. It's not Loctite perfect data. but there's a suggestion that it may also prevent herpes. But it's only viruses, right? So, and it does nothing for HPV. So bacterial STIs, you're absolutely at risk for. And so when I counsel people, I explain to them that uh, that this is only HIV prevention, and that part of the follow-up for PrEP is screening for STIs. I would argue that people that are on PrEP, because of the follow-up schedule that's recommended of quarterly testing, for most of my PrEP patients, I'm doing quarterly STI testing. So I'm actually capturing more frequent testing and more frequent evaluations than some of these guys get, because a lot of them get annual testing or twice a year testing. So we're testing more frequently. So, but it is important to emphasize that there is no protection here against gonorrhea, chlamydia, mycoplasma, trichomonas.
Or pregnancy.
Or pregnancy, another sexually transmitted condition. So it's very important to keep that in mind. So if you haven't done it already with this patient, with Demetrius, and clearly he's got gonorrhea and we'll treat him appropriately, if he hasn't already been screened for STIs, you got to do it. So that's an RPR for syphilis and nucleic acid testing, ideally for gonorrhea and chlamydia from exposed sites, all exposed sites, which means not just the cervix and not just the penis. So there's study after study after study that shows that if you do screening that doesn't include the pharynx and the rectum, you miss between 1/3 and 2/3 of STI cases, period. So you have to screen everywhere that's exposed. So it's very, very important to not just send them to the bathroom with the urine cup and think that you're covered. So it's important to screen for extra genital STIs as well. For gonorrhea, and you can use again, I have no stock in anybody. This is the kit that we have at UNC, the GenProbe Aptima Combo 2. This is, depending on your laboratory, it's probably been validated. Commercial labs have validated this from non-genital specimens. So it's okay to use this swab for the pharynx and for the rectum. Just remember that it's not like swabbing for strep throat. You don't do just the tonsils. You got to get the back of the throat. And for the rectum, you want to make sure that you actually sample the rectum and not just the anal canal. So the swab has to go in a fair amount so that you're not just essentially sampling the external skin. Very important. Then counseling the patient is really important, and with the adherence part, and we just got a few more slides left. I encourage people to think about adherence strategies. So the same kinds of things that you may counsel your HIV positive patients about, the same kinds of things that will work for PrEP patients. So pair pill taking with a task that happens every day, even on the weekend. A lot of my patients are young guys, and they plug in their cell phones religiously before bedtime. So I tell them to do their HIV medicines or their PrEP when they plug their cell phones in. But you can also set an alarm on your phone or your clock or something. Using a pill box helps. Keeping a dose on or near you, or a dose at work if you forget it. All of these are viable options here. The initial prescription is for 30 days with no refills. And the reason for that is twofold. One is so that you can assess their adherence and side effects, and also so that you can assess any potential changes in behavior. So that 30-day period, you just want to make sure that they're tolerating it okay, and you want to see them again. After that, they're kind of on autopilot. So after that, it's a 30-day prescription with 2 refills to meet that quarterly schedule, visit schedule. At least every 3 months, you would assess the same things. So adherence, side effects, and behaviors. HIV testing is at every single visit. Every single visit. And then there's the prescription renewal. Depending on how comfortable you are with your patient or your client following up, you can tell them that you're not going to give them the prescription until their test is in hand, your results are in hand. If you're doing the testing in your own clinic and you know that you're going to get that result promptly, then it's probably okay to go ahead and do the renewal. But just you can use the prescription as a
incentive.
Yes, thank you, incentive. At least every 6 months is a creatinine check. So you don't have to be doing urinalysis and kidney function testing at every visit. It's at least every 6 months. If you don't feel comfortable doing it that infrequently, you're absolutely free to do it more often. If you don't want to see the patient every 3 months and you want to see them monthly, you're also perfectly free to do that. These are the minimum suggested requirements, is at 3-month and 6-month intervals. And then I think it's important to at least every 6 months to determine the ongoing need for PrEP. So the idea of something called a season of risk, that if somebody is at risk for HIV based on not being in a relationship or being in a relationship with somebody living with HIV who's not taking their meds, for example, that might constitute a period of time where she or he would benefit from PrEP. If that changes, if circumstances change, then it may be okay to come off of it. The efficacy of restarting it later, you don't lose anything. So it's not like you're going to get resistance, because in order to get resistance, you have to be infected. So if you're uninfected and PrEP's doing its job, you can stop and start safely, keeping in mind that those wash-in and wash-out periods of 7 and 20 days respectively, like I showed on the prior slide. It's important to keep that in mind. So you don't want people to be rapid cycling on and off PrEP, but having periods of a month or two where they're on it, or a year when they're on it, and then they're in a new relationship and it's stable, they're both tested negative and they don't want to use it anymore, you can stop it. It's okay. So the big picture here is that PrEP is proven. This is real. It's FDA approved. And we know the FDA is not exactly liberal with approval of medications. It's well tolerated. It's highly effective if it's taken every single day. So this really is ready for prime time. And I would encourage you to begin kind of getting it out there more than what we're able to succeed doing now. So Michelle's going to say something here momentarily.
I am, and I'm going to say thank you for sticking with us. Almost everybody did. I want to ask a couple quick questions from Mr. Williams online and remind you, but it looks like everybody has. If you haven't checked in already, please do so in the chat box. I think, Mr. Williams, you have a $1 million question and a $15,000 question. The $15,000 question is, how can you get PrEP for free? And if the doctor won't give it to you, how do you get the manufacturer to give it to you? That's one. That's the $15,000 question. But here's really the $1 million question for North Carolinians. How do we get PrEP in areas with high infection rates but not high amounts of resources? For example, I'm in Fayetteville, North Carolina. Between Fayetteville and Fort Bragg, we have plenty of people contracting HIV and STIs. However, to even get considered on PrEP, you would need to go to RDU Chapel Hill, Charlotte. What can we do to help improve access to the medicine? I will call that the $1 million question. Answer whichever $ you wish to answer.
Yeah, and these are both really good questions. I'll address the lower dollar value question first. How do you get PrEP for free? You have to have lower income, so it has to be a single person less than $58,000 per year, and you have to have no insurance and essentially kind of no hope for insurance. So you can't have an active proffer of insurance from a partner or spouse. There are considerations there. The drug manufacturers ideally want you to be applying for Affordable Care Act plans. They want to provide co-insurance rather than paying for free. But if you are low income and you can show that, the application process is very easy. It's a 2-page application from the patient's side, and the client has to provide at least 2 W-2s or an income tax statement that shows that their income meets that requirement. You submit that to manufacturer within 24 hours, literally, barring weekends, so weekdays, the patient gets a call back from the manufacturer. It's extremely fast. So if you meet those requirements, you can get it for free. If you're not, if you have insurance and you want to get rid of the copay, the manufacturer copayment assistance cards that are there for people living with HIV, for example, they also work for PrEP. So if you don't have those in your clinic, you can ask your local Gilead sales representative for those copay cards. Although I think that it's actually now online, and you can print off the copay card. It asks you a few qualification questions up front. But what the copay card does is it makes, when you go to CVS or Walgreens and they say, give me $30, you show them the copay card and then you walk out without paying anything. So you're still paying your insurance premiums on the backside through your employer or through you writing a check to the insurance company, but the copay is free. So that's doable. The question about the $1 million question is one that we have lost some sleep over at NCA Tech, and I think part of it is, so how do we get PrEP providers into areas where there's high potential benefit but not a lot of resources right now? And you're absolutely right. We have a big swath of the state. Basically, the I-85 corridor is well covered. But the sand hills down to the coast and the mountains, we don't have providers up there. What we want is for some of you on the call and the webinar to say, yeah, I can do this, and let us know and let us list you. We would love it if you're in Mount Airy or Boone or Asheville or Fayetteville or Wilmington or Goldsboro, wherever you are. We want to be able to connect local clients to those providers so that they don't have to drive all the way up here, because it's silly and it's expensive and people aren't going to be able to do it, and they're not going to be able to sustain it. So we are also exploring some pilot programs within the public health system in the state. Durham is piloting a program right now where PrEP is being offered within the health department through a program that's being run with Lincoln Community Health Center, which is the federally qualified health center in Durham. So there are pilots that are sprouting up that are intended to determine if PrEP can be administered in health department settings. So one thing I'm personally interested in is determining if we have regional health departments, not every health department, but in specific targeted areas of the state where there's one provider willing to do it, and that it's not as far to drive. It's only 20 or 30 miles or 50 miles, not 150. So if we can come up with coverage for specific parts of the state, then that might be a solution. It's not perfect. Ideally, we want everybody to have access wherever they are, every client or potential client to have access to a provider wherever she or he is. But we're not going to get there realistically because we don't have that for HIV yet. But from my perspective, anybody who's writing for oral contraceptive pills should also be writing for PrEP. It's the same thing. It's sexual health. It may be a different face of the client. It may be a different gender of the client, but it's the same principle. It's sexual health. So it should be family medicine, obstetrics and gynecology, family planning clinics, STI clinics, general medicine, pediatrics, adolescent medicine. So all of those things, all of those providers should be the ones that take this up. And this is part of our efforts here, is to try to get the word out that this is not super hard to do and that there is backup, that we've got your back here. So if you start it and you want to get on board, we can help you with that.
Yes, that's the voice of a savvy evangelist. That's what that was. But we've got a really good technical specific question here. Ms. Harrington asks, how do you get payment for lab testing?
Yes, this really is
another dollar sign question.
Yeah, this really is the $1 million question. And this is a difficult question. For patients that are insured, it's essentially a non-issue. They may get a lab bill, but it's going to be at the insurance negotiated lab rate. For uninsured patients, this has been, so far, I'll be very honest, the major hurdle. Some counties, like Wake County, have programs where low-income and uninsured patients can get specific lab tests paid for. And it is possible to strip down the testing here to just the basics. We've also explored essentially cost sharing with health departments. So, for example, if you're a private practice provider and you're seeing a client for PrEP, you can have that client go to the local health department and get their STI and HIV screening and have the state lab of public health do that. As long as you have a mechanism for getting those results in a timely way. If you then from the clinical perspective, the only thing you'd have to have the patient pay for is creatinine. and really upfront the hepatitis B testing upfront. So there's an initial outlay, and then the creatinine, which is only twice a year, and at our UNC lab that's $36. So the creatinine is really the main critical test that you have to get. The STI and HIV testing can be essentially kind of farmed out to the state lab, and the state lab does fourth generation assays. So they're doing the kind of test that you would want, and they're doing the kind of test that the patient would pay a premium for because it's essentially kind of a specialty HIV test. So hopefully that answers that question.
We've got another question. Will uninsured patients need a physician's referral when contacting Gilead for PrEP? I think Mr. Williams was sort of getting at the same sort of issue.
Yeah. So the application for PrEP assistance from the manufacturer is two components. It's a 4-page document. 2 of the pages belong to the patient, and 2 of the pages belong to the provider. So what happens is the patient completes the address and demographic information and income information and signs a records release that's a HIPAA release. And then they're done. The patient or client is done. The other 2 pages, it's a prescription and basically a statement of medical need, essentially, that certifies that you're a provider who can write prescriptions and that you think it's appropriate for this person to get PrEP. The whole package, either all 4 pages or 2 separate things, that's what gets sent to Gilead, to the manufacturer. So the patient can't start the process without a provider available, and the provider has responsibilities as well. But it's not onerous. It's very easy to do. I just saw a patient last Thursday, who was uninsured, and I had to go through this process, and it was very easy to do. So it's not a very cumbersome process at all.
Okay. We're a little bit over time, but a lot of folks hung in there. So I'm going to say to the 47 of you still with us, if you've got any questions, Dr. Hurt's still ready. But I'm going to also remind everyone, we will be in touch. We are so glad you were part of this network webinar. We now consider you part of the network family for PrEP here at UNC. Everyone who is successfully registered is going to get a certificate of completion for this. We want you to become a place that's demonstrating that it's got its bona fides for PrEP training. Dr. Hurt has graciously, as usual, put his email address up. If you've got clinical questions, like really get in there, clinical questions, I encourage you to email him. That's what it's there for. If you have any questions about anything else, please feel free to email me. Oh, we've got one. One more question, a couple more questions. Will uninsured patients need a physician? Oh, we got that one already. Will low-income uninsured patients still be required to meet with their physician every 3 months? What do the guidelines say, and what do you say?
Yeah, the guidelines are pretty clear that the minimum number of visits for a patient that's on PrEP is essentially 4 per year. Quarterly visits every 3 months. I think there's some wiggle room there, and every 4 months to shave it down to 3 visits per year is reasonable. I would be uncomfortable, to be very frank, letting somebody go 6 months without touching base. If you know your patient really well, then these are the recommendations. So if you feel that the circumstances are different, you're free to veer from those recommendations. That's okay. I can tell you, I have had some patients that have emailed me and said, I can't get back for the visit that's scheduled in 2 weeks. Can I go ahead and get the prescription refilled, and then I'll see you in 4 weeks or 6 weeks? And I'm okay with that, because they've already shown that they're with it and they're kind of engaged, and I'm not worried about them. So I think it's really at your discretion. The guidelines say at least every 3 months for STI and HIV testing, and then at least every 6 months for the creatinine. The major costs that are incurred for patients are the provider bill and the lab costs. So the lab costs you can shave down through the cost sharing and through the minimization of lab tests that are going to be billed to the patient. But the face time with the provider is then the major hurdle. At UNC, we have the luxury of having a very generous charity care program that's structured to allow patients to get the care that they need without going bankrupt. Not every health system has that. And so it would be up to private providers if they want to do free care essentially, or not bill for certain visits, or do a lab only visit or a nurse only visit that would have a lower billing rate associated with it. So there are ways to get around it, but the FaceTime I think is important because of the counseling and the behavioral assessments and the adherence assessments. So there's a part there that it doesn't have to be an MD necessarily, with the associated cost. If it's a nurse or a physician assistant or somebody who's skilled at doing this work, that's okay. It doesn't have to be an MD with that associated bill, but the frequency is important.
Thank you. That's the kind of inside scoop you get when you stick around for some extra questions. I thought that was a really good question, because I bet there are a lot of clinicians who have similar patient scenarios, and you guys do know your patients best, and at the same time it's nice to hear how far would you go, Dr. Hurt. So Megan, would you do me a favor and advance the slides? So just one last word and we're going to let everybody go, because I think somebody else might be trying to get into this room. We are so glad you joined us. Your questions were terrific. We want you to get on the map if you feel like you're ready to provide PrEP, or we're ready to help support you and train you or give you resources if you think you're almost ready but not quite. The slide that's up right now shows the homepage for the North Carolina AIDS Training and Education Center, and then the website address beneath that is specifically for our PrEP page. Dr. Hurt did talk about that a little bit. There's information there for providers about protocols and frequently asked questions. There's information there for consumers. There's information for the PrEP curious. I'm going to remind everyone that they will receive an evaluation via email, and those evaluations are important to us. And we trotted out a new electronic system today. We worked with Link as a new platform, Link which uses Skype. And we also had a brand new media cart. So if you had any problems with the electronic side of this, you can let us know in the evaluation. Again, I may have mentioned this in the chat room, but this webinar will be posted to the NCA Tech website under videos and resources, maybe today, but by tomorrow at the latest. I think that we're going to call that last call. Thanks, everybody. We really appreciate your time. Be in touch if you want to follow up more on how you can become a PrEP provider and get on our big board. Thank you.
Thank you.
Bye, everybody.